Hi, welcome to our channel of ignou audiobooks, Indira Gandhi National Open University, School of Social Sciences, SOSS, Master's Degree Programs, MA in Psychology, MAPC, Second Year, MPCE01 Counselling Psychology, Block 2 Counselling, Models and Approaches, Unit-2 Behavioral Therapy, Cognitive Behavior Therapy and Approaches to Counselling, 2.0 Introduction. This unit deals with behavior therapy, cognitive behavior therapy and related issues. We start with behavior therapy, how it started and with what purpose, and proceed to give some of the techniques related to behavior therapy. The techniques such as systematic desensitization, exposure, flooding and aversion therapy are all discussed in this unit. Then we take up operant conditioning, techniques under which we discuss the positive reinforcement, participant modeling, and assertiveness training, etc. This is then followed by cognitive behavior therapy, in which we discuss its history, present the ABC model of CBT and describe the techniques of CBT in detail. We then present the hierarchical structure of ABC, model of cognitive behavior therapy and elucidate the principles underlying cognitive therapies. 2.1 Objectives. After completing this unit, you will be able to times define behavior therapy, times describe classical conditioning procedures in behavior therapy, times explain cognitive behavioral therapy, CBT, and its principles, times describe ABC model of CBT, times identify the difference between behavior therapy and cognitive behavioral therapy, CBT, and times explain the techniques involved in CBT. 2.2 Behavior therapy, behavioral psychology, or behaviorism, arose in the early 20th century in reaction to the method of introspection that dominated psychology at the time. John B. Watson, the father of behaviorism, had initially studied animal psychology. In the 1960s, behavior approaches emerged as a dramatic departure from the assumptions and methods that characterized psychoanalytic and humanistic therapies. They argued that psychology should concern itself only with publicly observable phenomena, i.e., overt behavior. According to behavioristic thinking, as mental content is not publicly observable, thus it cannot be subjected to rigorous scientific inquiry, the new practitioners of behavior therapy denied the importance of inner dynamics. Instead, they insisted that 1. Maladaptive behaviors are not merely symptoms of underlying problems, but rather are problems. 2. Problem behaviors are learned on the same ways normal behaviors are. And 3. Maladaptive behaviors can be unlearned by applying principles derived from research on classical conditioning, operant conditioning and modeling. Consequently, behaviorists developed a focus on overt behaviors and their environmental influences. Behavior therapy involves changing the behavior of clients to reduce dysfunction and to improve quality of life. Behavior therapy includes a methodology, referred to as behavior analysis, for the strategic selection of behaviors to change, and a technology to bring about behavior change, such as modifying antecedents or consequences or giving instructions. Behavior therapy represents clinical applications of the principles developed in learning theory. 2.2.1 History. Around 1920s, the application of learning principles to the treatment of behavioral disorders began to appear, but it had little effect on the mainstream of psychiatry and clinical psychology. Behavior therapy emerged as a systematic and comprehensive approach to psychiatric behavioral disorders in 1960s. Joseph Wolpe and his colleagues used Pavlovian techniques to produce and eliminate neuroses in cats. From this research, Wolpe developed systematic desensitization. At about the same time, Eysenck and Shapiro stressed the importance of an experimental approach in understanding and treating individual patients using modern learning theory. A Harvard psychologist B. F. Skinner also inspired the origin of behavior therapy. Skinner's students began to apply his operant conditioning technology developed in animal conditioning laboratories to human beings in clinical settings. Classical conditioning procedures have been used in two major ways. First, they have been used to reduce or decondition anxiety responses. Second, they have been used in attempts to condition aversive stimuli. His most commonly used classical conditioning procedures are times systematic desensitization, times exposure therapy, and times aversion therapy. Let us take up each of these and discuss. 2.2 Systematic desensitization. In 1958, Joseph Wolpe introduced systematic desensitization. This is actually learning-based treatment for anxiety disorders. Wolpe viewed anxiety as a classical, conditioned response. His goal was to eliminate anxiety by using a procedure called counterconditioning. In this, a new response that is incompatible with anxiety is produced. For example, relaxed state which is incompatible with anxiety state. This relaxed state is conditioned to the anxiety-arousing conditioned stimulus, CAs, like for instance fear of a closed room or fear of heights, etc. It is based on the behavioral principle of counterconditioning, whereby a person overcomes maladaptive anxiety elicited by a situation or an object by approaching the feared situation gradually in a psychophysiological state that inhibits anxiety. In systematic desensitization, patients attain a state of complete relaxation and are, then, exposed to the stimulus that elicits the anxiety response. The negative reaction of anxiety is inhibited by the relaxed state, a process called reciprocal inhibition. Instead of using actual situations or objects that elicit fear, patients and therapists prepare a graded list or hierarchy of anxiety-provoking scenes associated with a patient's fears. The learned relaxation state and the anxiety-provoking scenes are systematically paired in treatment. Thus, systematic desensitization consists of 3 steps times hierarchy construction times relaxation training times desensitization of the fear-evoking stimulus. Step 1. Hierarchy construction. When constructing a hierarchy, clinicians determine all the conditions that elicit anxiety. And then patients create a hierarchy list of 10 to 12 scenes that produce anxiety, and these are then put in order of increasing anxiety. In the box below is given an example of a hierarchy construction used in the systematic desensitization treatment of a test-anxious college student. Scene: hierarchy of anxiety-arousing scenes. Hearing about someone else who has a test, least anxiety-provoking. Instructor announcing that a test will be given in 3 weeks. Instructor reminding class that there will be a test in 2 weeks. Overhearing classmates talk about studying for the test, which will occur in 1 week. Instructor reminding class of what it will be tested on in 2 days. Leaving class the day before exam, studying the night before test, getting up morning of the test, walking toward the building where the exam will be given, walking into the exam room, instructor walking into the room with the test, tests being distributed, reading the test questions, watching others finishing the test, seeing a question I cannot answer, instructor waiting for me to finish the test. High anxiety provoking. Step 2. Relaxation training. Relaxation training can help people control their physiological responses in stressful situations. These techniques produce physiological effects opposite to those of anxiety, that is slow heart rate, increased peripheral blood flow, and neuromuscular stability. A variety of relaxation methods have been developed. Most methods use progressive relaxation, also known as somatic relaxation training, developed by the psychiatrist Edmund Jacobson, it provides a means of voluntarily reducing or preventing high level of arousal. Patients relax major muscle groups in a fixed order, beginning with the small muscle groups of the feet and working towards shoulders, neck, face and head, etc. Moving from lowest extremities to the head is called cephalcaudal. Of course, one can also start with head muscles, face muscles and move down to neck, etc. and then on to the extremities. Some clinicians use hypnosis to facilitate relaxation or use tape-recorded exercise. To allow patients to practice relaxation on their own, mental imagery is a relaxation method in which patients are instructed to imagine themselves in a place associated with pleasant relaxed memories. Such images allow patients to enter a relaxed state or experience. The physiological changes that take place during relaxation are the opposite of those induced by the stress responses that are part of many emotions. Muscle tension, respiration rate, heart rate, blood pressure, and skin conductance decrease. Relaxation increases respiratory heart rate variability, which is an index of parasympathetic tone. In the box below, relaxation step by step are given, with its focus on full cleansing breaths. Deep breathing is a simple, yet powerful, relaxation technique. It's easy to learn, can be practiced almost anywhere, and provides a quick way to get your stress levels in check. Deep breathing is the cornerstone of many other relaxation practices, too, and can be combined with other relaxing elements such as aromatherapy and music. All you really need is a few minutes and a place to stretch out. How to practice deep breathing? The key to deep breathing is to breathe deeply from the abdomen, getting as much fresh air as possible in your lungs. When you take deep breaths from the abdomen, rather than shallow breaths from your upper chest, you inhale more oxygen. The more oxygen you get, the less tense, short of breath, and anxious you feel. So the next time you feel stressed, take a minute to slow down and breathe deeply. Times sit comfortably with your back straight. Put one hand on your chest and the other on your stomach. Times breathe in through your nose. The hand on your stomach should rise. The hand on your chest should move very little. Times exhale through your mouth, pushing out as much air as you can while contracting your abdominal muscles. The hand on your stomach should move in as you exhale, but your other hand should move very little. Times continue to breathe in through your nose and out through your mouth. Try to inhale enough so that your lower abdomen rises and falls. Count slowly as you exhale. If you have a hard time breathing from your abdomen while sitting up, try lying on the floor. Put a small book on your stomach and try to breathe so that the book rises as you inhale and falls as you exhale. Progressive muscle relaxation for stress relief. Progressive muscle relaxation is another effective and widely used strategy for stress relief. It involves a two-step process in which you systematically tense and relax different muscle groups in the body. With regular practice, progressive muscle relaxation gives you an intimate familiarity with what tension as well as complete relaxation feels like in different parts of the body. This awareness helps you spot and counteract the first signs of the muscular tension that accompanies stress. And as your body relaxes, so will your mind. You can combine deep breathing with progressive muscle relaxation for an additional level of relief from stress. Progressive muscle relaxation sequence: times right foot, times left foot, times right calf, times left calf, times right thigh, times left thigh, times hips and buttocks, times stomach, times chest, times back, times right arm and hand, times left arm and hand, times neck and shoulders, times face. Most progressive muscle relaxation practitioners start at the feet and work their way up to the face. For a sequence of muscle groups to follow, see the box to the right. Times loosen your clothing, take off your shoes, and get comfortable. Times take a few minutes to relax. Breathing in and out in slow, deep breaths. Times when you are relaxed and ready to start, shift your attention to your right foot. Take a moment to focus on the way it feels. Times slowly tense the muscles in your right foot, squeezing as tightly as you can. Hold for a count of 10. Times relax your right foot. Focus on the tension flowing away and the way your foot feels as it becomes limp and loose. Times stay in this relaxed state for a moment, breathing deeply and slowly. Times when you are ready, shift your attention to your left foot. Follow the same sequence of muscle tension and release. Times move slowly up through your body, legs, abdomen, back, neck, face, contracting and relaxing the muscle groups as you go. Step 3. Desensitization of the anxiety-provoking stimulus. In the final step, called desensitization, the patient proceeds systematically through the list from the least to the most anxiety-provoking scene while in a deeply relaxed state. In fact, they vividly imagine the situation as is given in the list, and as they imagine and as they are in the relaxed state, the scene, even if evokes anxiety, the anxiety does not bother the individual. In case it does, then the patient is made to relax once again all the more, and the same scene is imagined until the anxiety is no more evoked when visualizing the concerned anxiety-provoking situation. Once the patient is totally relaxed even under the anxiety-provoking situation, the patient is asked to move to the next item in the list that is anxiety-provoking. The same process as above is repeated until the situation no more evokes anxiety, then the patient moves on to the third item in the list, and so on. The rate at which the clients progress through the list is determined by their responses to the stimuli. When patients can vividly imagine the most anxiety-provoking scene of the hierarchy with equanimity, they experience little anxiety in the corresponding real-life situation. 2.2.3 Exposure and extinction approach. From a behavioral point of view, phobias and other fears result from classically conditioned emotional responses. The conditioning experience is assumed to involve a pairing of the phobic object, fear of heights, let us say, with an aversive, unconditioned stimulus, UCS. For example, if a person has a fear of heights, then put him at a height, UCS, where he has no way to come down except with the help of a ladder that you may provide him later. As a result, the phobic stimulus, height, becomes a conditioned stimulus, CAS, that elicits the conditioned response, CR, of anxiety. Continuously staying exposed to the aversive stimulus, heights, in course of time brings down the anxiety and the extreme negative reaction. As this process of exposure is repeated again and again, the patient does not react negatively or with fear when exposed to heights. Thus, according to this formulation, the most direct way to reduce the fear is through a process of classical extinction of the anxiety response. The client may be exposed to real-life stimuli or asked to imagine scenes involving the stimuli. These stimuli will evoke considerable anxiety, but the anxiety will be extinguished in time if the person remains in the presence of the fear-evoking stimulus, heights, and the UCS, anxiety, does not occur. Some critics of exposure treatment are concerned that the intense anxiety evoked by the treatment may worsen the problem or cause clients to flee from the treatment, but experimental research has proved this technique a very effective treatment for extinguishing anxiety in both animals and humans. Advances in computer technology have made it possible to present environmental cues in virtual reality, VR, for exposure treatment. Virtual reality involves the use of computer technology to create highly realistic virtual environments that stimulate virtual actual experience so vividly that they evoke many of the same reactions that a comparable real-world environment would. Beneficial effects have been reported with virtual reality exposure of patients with height phobia, fear of flying, spider phobia, and claustrophobia. Much experimental work is being done in the field. 2.2.4 Aversion therapy. For some clients, the therapeutic goal is not to reduce anxiety but actually to condition anxiety to a particular stimulus that triggers deviant behavior. In aversion therapy, the therapist pairs a stimulus, drinking alcohol, that is attractive to the client, the CAs, with a noxious UCS, vomiting due to an injection given immediately before taking alcohol, in an attempt to condition an aversion to the CAs, alcohol. When a noxious stimulus, vomiting as punishment, is presented immediately after a specific behavioral response, theoretically, the response is eventually inhibited and extinguished. Many types of noxious stimuli are used, which include, for instance, electric shocks, substances that induce vomiting, corporal punishment, and social disapproval. The negative stimulus is paired with the behavior, which is thereby suppressed. The unwanted behavior may disappear after a series of such sequences. Aversion therapy has been used for alcohol abuse, paraphilias, child molesters, and other behaviors with impulsive or compulsive qualities, but this therapy is controversial for many reasons. For example, punishment does not always lead to the expected decreased response and can sometimes be positively reinforcing. 2.2.5 Operant conditioning treatments. The term behavior modification refers to treatment techniques that apply operant conditioning procedures in an attempt to increase or decrease a specific behavior, like positive reinforcement, extinction, negative reinforcement, or punishment. Positive reinforcement, when a behavioral response is followed by a generally rewarding event, such as food, avoidance of pain, or praise, it tends to be strengthened and to occur more frequently than before the reward. This principle has been applied in a variety of situations. In the inpatient hospital wards, patients with mental disorder receive a reward for performing a desired behavior, such as tokens that they can use to purchase luxury items or certain privileges. The process, known as token economy, has successfully altered undesirable behaviors to desirable behaviors. Flooding, sometimes called implosion, is similar to graded exposure in that it involves exposing the patient to the feared object in vivo. However, there is no hierarchy. It is based on the premise that escaping from an anxiety-provoking experience reinforces the anxiety through conditioning. Thus, clinicians can extinguish the anxiety and prevent the conditioned avoidance behavior by not allowing patients to escape the situation. In a variant called imaginal flooding, the feared object or situation is confronted only in the imagination, not in real life. Many patients refuse flooding because of the psychological discomfort involved. It is also contraindicated when intense anxiety would be hazardous to a patient. Example, those with heart disease or fragile psychological adaptation. The technique works best with specific phobias. 3. Participant modeling. In participant modeling, patients learn a new behavior by imitation, primarily by observation, without having to perform the behavior until they feel ready. Learning by watching others' behavior is also called observational learning. Just as irrational fears can be acquired by learning, they can be unlearned by observing a fearless model confront the feared object. The technique has been useful with phobic children who are placed with other children of their own age and sex who approach the feared object or situation with adults. A therapist may describe the feared activity in a calm manner that a patient can identify, or the therapist may act out the process of mastering the feared activity with a patient. Sometimes, a hierarchy of activities is established, with the least anxiety-provoking activity being dealt with first. The participant modeling technique has been used successfully with agoraphobia by having a therapist accompany a patient into the feared situation. In a variant of the procedure, called behavior rehearsal, real-life problems are acted out under a therapist's observation or direction. 4. Assertiveness training. Assertive behavior enables a person to act in his or her own best interest, to stand up for herself or himself without undue anxiety, to express honest feelings comfortably, and to exercise personal rights without denying the rights of others. Two types of situations frequently call for assertive behaviors. Times setting limits on pushy friends or relatives, and times commercial situations, such as countering a sales pitch or being persistent when returning defective merchandise. Early assertiveness training programs tended to define specific behaviors as assertive or non-assertive. Social skills training. Social skills training have been found to be efficacious for depression and schizophrenics. These training programs cover skills in the following areas: times conversation, times conflict management, times assertiveness, times community living, times friendship and dating, times work and vocation, and times medication management. Each of these skills has several components. For example, assertiveness skills include the following: times making requests, times refusing requests, times making complaints, times responding to complaints, times expressing unpleasant feelings, times asking for information, times making apologies, times expressing fear, and times refusing alcohol and street drugs. Each component involves specific steps. 2.3 Cognitive Behavioral Therapy (CBT). In 1960's cognitive revolution in psychology occurred, and by 1970 many behavior therapists influenced by it began to call it cognitive behavioral therapy. Cognitive behavioral therapy (CBT) is an amalgam of two therapies: cognitive therapy (CT) and behavioral therapy. The term cognitive behavioral therapy is a very general term for a classification of therapies with similarities. 2.3.1 Brief history. CBT is a form of psychotherapy that emphasizes the important role of thinking in how we feel and what we do. It does not exist as a distinct therapeutic technique. Beck and Ellis are two names associated with cognitive behavioral therapy. Albert Ellis' system originated in the early 1950s, developed rational emotive therapy, RET, the first discrete therapeutic approach to CBT. Aaron T. Beck, inspired by Albert Ellis, developed cognitive therapy in the 1960s. Ellis developed and popularized the ABC model of emotions and later modified the model to the ABCD approach. In the 1990s, Ellis renamed his approach Rational Emotive Behavior Therapy. Behavioral therapy focuses on a person's actions and aims to change unhealthy behavior patterns. In the 1960s, Aaron Beck, MD, developed his approach called cognitive therapy. CT focuses on a person's thoughts and beliefs and how they influence a person's mood and actions, and aims to change a person's thinking to be more adaptive and healthy. Aaron Beck proposed the basic principles of CBT, which can be applied to a variety of psychiatric and medical problems. It focuses on identifying and changing maladaptive patterns of information processing and related behaviors. CBT methods are rooted in a psychological understanding of symptoms. It shares three fundamental propositions. 1. Cognitive activity affects behavior. 2. Cognitive activity may be altered and monitored. 3. Desired behavior change may be effective through cognitive change. Beck's approach became known for its effective treatment of depression. Cognitive behavioral approach is based on the assumption that anxiety, depression, and negative emotions develop from maladaptive thought processes. 2.3.2 ABC model of CBT. This model records a sequence of events in terms of A. Activating event described as a trigger, B. Beliefs, e.g. the thoughts that occur when the activating event happens, C. Consequences, how you feel and behave when you have those beliefs. This ABC technique of irrational belief has proven as the major tool in cognitive therapy. The main aim of this technique is to focus around the causes that develop irrational belief and has to be recorded during the therapy. CBT helps a person focus on his or her current problems and how to solve them. Both patient and therapist need to be actively involved in this process. The therapist helps the patient learn how to identify distorted or unhelpful thinking patterns, recognize and change inaccurate beliefs, relate to others in more positive ways, and change behaviors accordingly. There are several approaches to cognitive behavioral therapy, including the following: 1. Rational emotive behavior therapy, 2. Rational behavior therapy, 3. Rational living therapy, 4. Cognitive therapy, and 5. Dialectic behavior therapy. 2.3.3 Goals of CBT. CBT focuses on a here and now orientation. The goals of CBT are times to challenge the thoughts about a particular situation by identifying the cognitive traps, times to help the patient to identify less threatening alternative, and times to test out these alternatives in the real world. Times it also aims to leave clients at the completion of therapy with the freedom to choose their emotions, behaviors, and lifestyle within physical, social, and economic restraints. Times to finally effect profound and lasting change in the underlying belief system of the client, rather than simply eliminating the presenting symptoms. Times to make the client equipped with self-help techniques that enable coping in the long-term future. 2.3.4 Techniques. Principles of CBT. CBT is based on several principles. These are: times it is brief and time-limited, times it is structured, directive, and problem-oriented, times it is based on the cognitive behavioral model of emotional disorders, times it is a collaborative effort between the CBT practitioner and the client seeking treatment and requires a sound therapeutic relationship. They work together to try to understand the person's difficulties and what may be contributing to them. Times the sessions of CBT are typically 1 hour in length. Times the clients are guided to discover new ways of thinking for themselves with specific questions. Times it is often based on an education model. Times it relies on the inductive method, a scientific approach using logic and reasoning. Times it uses between session practice as a central feature for people to put into practice what they have learned. New behaviors are initially tested in safe situations. For example, the practitioner's office. Times it focuses on the present. The past cannot be changed, but the way we think about the past can be changed. 2.3.5 Levels of cognition. 3 major levels of cognition relevant to the practice of CBT were identified by Beck and his colleagues. These are I. Full consciousness, 2. Automatic thoughts, and 3. Schemas. I. Consciousness is a state in which rational decisions are made with full awareness. 2. Automatic thoughts are more autonomous, often private cognitions that flow rapidly in the stream of everyday thinking and may not be carefully assessed for accuracy or relevance. 3. Schemas, the deepest level of cognition, are fundamental rules for information processing which are shaped by developmental influences and other life experiences. Schemas that play a major role in regulating self-worth and behavioral coping strategies are a frequent target of CBT. Examples of automatic thoughts and maladaptive schemas. automatic thoughts, maladaptive schemas. I should be doing better in life. I must be perfect to be accepted. I have let him her down. I am a fake. I always keep messing things up. If I choose to do something, I must succeed. I cannot handle it. I am unlovable. It is too much for me. No matter what I do, I won't succeed. I don't have much of a future. The world is too frightening for me. Things are out of control. Others cannot be trusted. I feel like giving up. I must always be in control. I will never be able to get this done. I am stupid. Something bad is sure to happen. Other people will take advantage of me. 2.3.6 Techniques used in CBT. The CBT techniques described below are useful in eradicating certain problems in a time-bound manner which stem from maladaptive thoughts and behaviors. The techniques are given in the following section. Cognitive rehearsal. In this technique, the therapist asks the patient to recall a problematic situation of the past. The therapist and patient both work together to find out the solution to the problem. 2. Validity testing. This is one of the first cognitive therapy techniques. Every disorder or disease must have supporting evidence, and the therapist asks the patient to defend his feelings, thoughts and beliefs with objective evidence. The faulty nature or invalidity of the beliefs of the patient is exposed if he is unable to produce any kind of objective evidence. 3. Writing in a diary journal. It is the practice of maintaining a diary to keep an account of the situations that arise in day-to-day life. This is a detailed diary which notes every emotion, thought and belief. The therapist and the patient later collectively assess the diary journal to analyze how they actually affect the behavior of the individual. 4. Guided discovery. The purpose of this technique is to enable the patient realize his cognitive distortions. The patient becomes aware of his cognitive distortions through a series of questions and answers. Systematic positive reinforcement. Cognition can be changed over a period of time by positive encouragements and small rewards. It is one of the cognitive behavioral therapy techniques in which positive behaviors of a person are rewarded with a positive reinforcement. A reward system is established for the reinforcement of certain positive behaviors. Just like positive reinforcement, withholding the reinforcement is also equally important. It helps in eradicating a maladaptive behavior. 6. Aversive conditioning. This technique makes use of dissuasion for lessening the appeal of a maladaptive behavior. The patient is exposed to an unpleasant stimulus while engaging him in a particular behavior or thought for which he has to be treated. Thus, the unpleasant stimulus gets associated with such thoughts, behaviors, and then the patient exhibits an aversive behavior towards them. 7. Modeling. In modeling, the patient makes use of the behavior of the therapist as a model in order to solve his/her problems. The therapist performs role-playing exercises which are aimed at responding in an appropriate way to overcome difficult situations. 8. Homework. The therapist gives a set of assignments to patients as homework. The patient takes notes during the session, reviews the audio tapes of a particular session or reads article books that are related to the therapy. 2.3.7 Hierarchical structure of ABC. People experience events in their life. These events lead to assumptions, right or wrong, being made about that event. Once the assumption has been made, it gets placed into our subconscious mind. This assumption then generates beliefs or conclusions. These beliefs can either be true, accurate, or false, inaccurate. From these beliefs comes our thinking and self-talk. From our thinking and self-talk comes our feelings and emotions. Finally, our feelings and emotions give rise to our behavior and actions. The following diagram displays the way in which One wrong assumption can give birth to many beliefs, which in turn gives birth to many more self-talk, emotional and behavioral issues. Looking at this hierarchy structure, true change, that is lifelong and effective, can only happen if the core assumptions are uncovered and dealt with. The assumption is the base level which determines everything else in the hierarchy. If change was attempted by only addressing the behavioral level, sooner or later the emotions and self-talk would cause that change to be negated. Willpower cannot override the internal feelings below the behavioral level. If change was attempted at the emotions and feelings level, then changed behavior will follow, but at some point internal self-talk, beliefs and assumptions will be too much to bear and cause the emotions then actions to revert back. Thus cognitive therapy involves getting down to the beliefs level. Down at this level, lasting change can begin to occur. Change in the belief system results in change in all the levels above it. The only problem is that the underlying assumption that caused the false belief and then conflict is still lurking. It means that if the assumption itself is incorrect, wrong, false, then it will generate other false beliefs. What can occur in therapy then is that false belief upon false belief are traced, faced and replaced, but there always seems to be more. The only way to achieve true freedom from the shackles is to uncover the core assumption at the base level. Once you find this and confront it, the false beliefs take care of themselves and no new ones are created. Your self-talk changes, your emotions and feelings turn positive and your actions follow suit. 2.4 Summary. Behavior therapy has been used successfully for a variety of disorders and can be easily taught. It requires less time than other therapies and is less expensive to administer. Although useful for circumscribed behavioral symptoms, the method cannot be used to treat global areas of dysfunction. Example, neurotic conflicts, personality disorders. Controversy continues between behaviorists and psychoanalysts, which is epitomized by Eysenck's statement. Learning theory regards neurotic symptoms as simply learned habits. There is no neurosis underlying the symptoms, but merely the symptom itself. Get rid of the symptom and you have eliminated the neurosis. Analytically oriented theorists have criticized behavior therapy by noting that simple symptom removal can lead to symptom substitution when symptoms are not viewed as consequences of inner conflicts and the core cause of the symptoms is not addressed or altered. The result is the production of new symptoms. Whether this occurs remains open to question. However, whereas CBT is based on the concept that mental disorders are associated with characteristic alterations in cognitive and behavioral functioning and that this pathology can be modified with pragmatic problem-focused techniques. CBT is well established as a treatment for depression, anxiety disorders, and eating disorders. There is growing evidence that it can play an effective role in the clinical management of a large range of other disorders, including schizophrenia, bipolar disorder, and access to conditions. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.